I am Dr. Paranthaman, Professor and Head of the Department of Medicine, Government Kilpavk Medical College, and Secretary City Physician Meet Association, Chennai. So, we come across a lot of patients with breathlessness, breathing problem, and the leg swelling, and sometimes palpitation to the hospital. When we clinically examine and go to the history, they say there's chest discomfort and breathlessness, both are there on exertion. And if you look into the clinical presentation, there is a leg swelling, bilateral pitting peel edema will be there, and the elevated neck veins, jugular venous pressure will be elevated. Then you look into the auscultation, there are bilateral basal crepitations, so the lung fields on examining the chest. The pulse, there will be irregular pulse on palpating the radial artery. If that is a scenario, what we do come across, we do is that immediately we take basal investigations like X-ray chest, ECG, and echocardiography, because we have diagnosed as something related to the heart failure. So, we go for an ECG. The ECG, there will be atrial fibrillation, irregular heart rate with there is low voltage complexes, and during X-ray chest there will be a cardiomegaly, and we do echocardiography to confirm the findings in the heart on the X-ray. They shows the left ventricular wall thickening in the echocardiography. If that is a scenario, if there is a wall thickness increase in the echocardiography and there is a cardiomegaly in the X-ray, but ECG is showing not very tall T waves, tall R waves and small voltage complexes in the ECG, which is something mismatch, that is called clinical radiological mismatch is there. And because having the features, all the features of heart failure by symptom signs and the features of the X-ray ECG, there are signs, but there is a discordance between the signs clinically as well as the investigation wise. So, we are the problem. Then what to do further? We have done echocardiography, we have done a baseline test, still we are not able to identify the cause of the disease. Now, I'll ask Dr. Prabhu, what you do if such scenario comes to you?
Thank you, Professor Paranthaman. I am Dr. Prabhu. I am the Senior Consultant, Head of the Department of Nuclear Medicine at the Tamil Nadu Government Multispeciality Hospital. I am also the President-elect of Society of Nuclear Medicine India and the founder member of World Federation of Cardiac Imaging and Clinical Cardiology. What Professor Paranthaman was trying to do is on a vulnerable patient, he was trying to see the patient from inside out, because he found there are strong clinical signs of heart failure, and then the patient's findings, the investigation findings were not in agreeing with what his strong clinical suspicion is. So, he is trying to see the patient's heart from outside in. In nuclear medicine, what we do is we see the patient's heart from inside out. We inject a small quantity of a tracer. When we say tracer, it is nanogram, microgram level of substance that is intravenously injected, and this takes part in the body metabolism. Either we can see the cardiac perfusion, that is the blood flow to the heart that is happening in the microvasculature. We know very well all the epicardial and major coronary arteries form only about 5% to 7% of the coronary circulation. Remaining is by the coronary microvasculature. These are the vessels that regulate the blood flow in the heart, and these vessels are so too small for any dye or any other investigative intervention procedures to enter inside, and this is where we come in. So, we introduce a small amount of radio tracer. It can be an analog of a potassium ion, which is more intracellularly concentrated, or it can be a tracer that goes into the mitochondrium, where a normal myocardium, which is rich in mitochondrium, the ischemic myocardium has decreased mitochondrium, or the infarcted myocardium, it is fibrous and doesn't contain any mitochondrium. All these things we will be able to quantify. And this tracer, as it is passing through the cellular metabolism, it will be emitting invisible radiation in the form of gamma rays. And these gamma rays will be able to trap with a specially designed sophisticated equipment called as a PET camera, or it can be a PET camera if the tracer is a positron emitting tracer, we'll be able to capture it, and these electronically captured images will be converted into three-dimensional images, heart. We can exactly quantify what exactly the blood flow that is happening within the blood vessels of the heart. And inside the myocytes, whatever the cardiac metabolism, whether it is a oxygen metabolism or nitrogen 13 metabolism, fluorine 18 in the form of glucose metabolism, all these things we'll be able to capture. We can see three-dimensionally what is happening inside the myocytes. In addition to that, we can also see whether there are certain molecules which are getting proteins, abnormal proteins that are getting deposited around the myocytes, literally compressing and squeezing the myocardium from functioning normally. That may present as a ischemic heart disease. In addition to that, we can also see the nerve supply to the myocardium, and by using adrenergic neurons, adrenergic receptors, where the electrical signals are not in coherence with each other, we can see the neuronal conduction mechanism by nuclear imaging techniques. Either it can be, we can see what the blood flow into the heart, we can see the myocardial metabolism, we can see the nerve supply to the heart, and also the heart that is molecules that are getting deposited and they are squeezing the cardiac function. All these things can be appreciated and quantified. What you are clinically describing, sir, is more likely amyloid deposition, and that is what it is deposited in huge quantities. These proteins are relentlessly deposited, they are redundant proteins, and they interfere into the cardiac mechanism by mechanically compressing the myocytes and performing it and preventing its performance so that the patient develops clinically symptomatic.
Absolutely, absolutely correct. But that's what we suspected clinically, and based on the investigations, we suspected only amyloidosis. Then we have submitted the patient to the imaging that very well came out as the amyloid, the cardiac amyloidosis. So wonderful learning from this thing. Thank you very much, sir. You are given a wonderful insight about how the molecular mechanisms takes place, how the metabolisms takes place inside the cell with the mitochondria, all these things, and the usefulness of perfusion scan in such individuals, so that we can clarify or you are identify what is the exact problem we are dealing with. Thank you.
Thank you, sir. Now that you have suspected cardiac amyloidosis, what we do in nuclear imaging is we do what is called as pyrophosphate scan. And this pyrophosphate scan, it gets deposited into the microcalcifications that is happening into the cells, and we will be able to quantify it. And if the scan is positive, we can get an objective information to the extent what the patient's amyloid is getting deposited. Now that beautiful drugs have come up that interfere with the uptake metabolism of the amyloid proteins, and so that maintain the integrity of the transport proteins, and the disease limitation happens.
Dr. Prabhu,
thank you, sir.
Dr. Prabhu, is it possible to differentiate amyloidosis from sarcoidosis, or both are the disease of restrictive?
Basically infiltrative heart disease. It is possible to definitely differentiate. But then for imaging cardiac sarcoidosis, we have to do an FDG PET, where there is increased metabolism that is happening inside. And whereas in amyloid, we prefer to do, even though PET imaging agents are available, the SPECT imaging agents, the pyrophosphate scan is more extensively available, it is a lot cheaper, and a lot of studies are telling that it is, if it is accurate, if not better than that of PET imaging tools. So that is why it is easy to diagnose, sir.
Thank you very much, Dr. Prabhu. You have really given an eye-opener for this diagnosing such difficult cases when we face clinically the challenges in my clinical practice. Thank you very much.
Thank you, Professor Paranthaman. Thank you, sir.